Hi everyone, my name is Rachel Larmer, and in this Journal Club presentation, I'll be discussing a study that was published in November of 2019 titled Oral Vancomycin may be associated with earlier symptom resolution than metronidazole for hospitalized children with non-severe Clostridioides difficile infections. We know that CDI infections are the most commonly recognized cause of infectious diarrhea in healthcare, but there's very little evidence in children. There is a weak recommendation with a low quality of evidence for both oral metronidazole and oral vancomycin for 10-day treatment of initial episode non-severe cases in children. Both medications do work differently in the body, and metronidazole is a much more cost-effective choice. In the 2018 guidelines, there was an update that changed the recommendation for adult non-severe cases, but not for children. The objective of this study was to compare the clinical outcomes of hospitalized children with non-severe CDI infections treated with oral metronidazole versus oral vancomycin. Since metronidazole is a very popular option, perhaps due to the cost, they wanted to see if it actually did work better. It was a multi-center observational retrospective propensity score weighted cohort study of patients under 18 years old hospitalized at the Johns Hopkins Hospital, Bayview Medical Center, or Howard County General Hospital with non-severe CDI between January 2012 and December of 2018. A clinical microbiology lab provided investigators with a list of all children with a positive stool nucleic acid amplification test for C. diff toxin B during the study period. The investigators then performed a manual chart review using the Epic Care Everywhere network and the Chesapeake Regional Information System for Our Patients, which is CRISP. They used this to evaluate the inpatient, outpatient, and emergency department information for children in the state of Maryland and the District of Columbia, and also inpatient records. The surveillance cases, which are basically the causations of the onset of the infection, were defined as community onset, which is symptoms within 3 days of admission and no previous admission within the past 28 days, facility onset, community onset. Facility-associated community onset healthcare, which is history of hospital admission in the past 28 days, and healthcare facility onset, which is onset greater than 3 days after admission. 192 patients met the eligibility criteria, and a large majority received metronidazole. There was no valid definition for non-severe CDI in children, so they used the adult criteria, which is peripheral white blood cell count less than 15,000 cells and a serum creatinine level less than 1.5. They also could not have hypotension, ileus, or megacolon, and they could not require intensive care unit care. Inclusion into the study basically made it so they were a pediatric patient with a confirmed non-severe CDI infection, and any patient who didn't meet the inclusion criteria, or if they were started on vancomycin or metronidazole initially and then transitioned to the opposite therapy after 48 hours, were excluded, as well as patients who received metronidazole as a tapered and pulsed regimen. Exclusion from CDI testing, so the laboratory didn't even get these tests to the investigators, were if the children had formed stools, a previous CDI test within 7 days, or if they'd received a laxative within 48 hours. The exposed group was metronidazole and the unexposed group was vancomycin. Patients were sorted into the appropriate groups based on if they received treatment for the duration of therapy or if they were started on the opposite agent but then switched to the other therapy within 48 hours. The primary endpoint was resolution or improvement of diarrhea by the treating clinician within 5 days of antibiotic initiation. If the patient was discharged before day 5 and they had no post-discharge records available from Epic, the MITCHART, or CRISP, an assumption was made that the resolution or an improvement occurred by day 5. The secondary endpoints were recurrence of disease within a 12-week period and incident vancomycin-resistant enterococci isolation from clinical cultures within 12 weeks. Statistical analysis was done, and it was extensive. There was multivariable logistic regression where they calculated propensity scores for each patient, with the dependent variable being metronidazole therapy. The covariates they used were previous episode of CDI, chemotherapy, stem cell transplantation, organ transplant, ulcerative colitis, Crohn's disease, and surveillance cases. The patients in the exposure group, which was metronidazole, were weighted by the inverse of the propensity score. Patients in the unexposed group, which is vancomycin, were weighted by the inverse of 1 minus the propensity score, and they created this new population based on these baseline characteristics between the groups. The individuals who received an unexpected antibiotic were given a higher weight, and the unexpected antibiotic was given a higher weight, and then the expected antibiotic was given a decreased weight since they were already adequately represented. They then used the weighted t-test or chi-square test to compare the baseline characteristics after this inverse probability of treatment weighting was applied, and standardized differences less than 10% were considered appropriately balanced. In the final analysis, they used these weighted logistic regression to estimate the odds ratios and 95% confidence intervals for the outcome, and adjusted for variables with a standardized difference greater than 10%. A two-sided p-value less than 0.05 was considered statistically significant for all tests. Baseline characteristics. All characteristics other than the previous episode of a C. diff infection within the past 2 years were not statistically significant, such as age, gender, race, ethnicity, pre-existing medical conditions, and the surveillance categories. The average ages of patients were 8 to 9 years old. Patients were mostly white, and in the weighted cohort, most cases were healthcare facility onset at both groups. The endpoints were all based on the weighted propensity cohort. The primary endpoint, like we said, was clinical improvement by day 5, which was higher in the vancomycin group. The secondary endpoint, which was recurrence of disease, was not statistically different or clinically significantly different between the two groups, but it was higher in the metronidazole group. And the last secondary endpoint, which was incidence of VRE, was higher in the vancomycin group, but not by much. There were additional analyses that were done. So 40 children did not experience clinical resolution by day 5 on initial oral metronidazole. 20 of these patients, which is 50%, were then changed to oral vancomycin. None of the 7 patients who failed on vancomycin initially were changed to oral metronidazole. The median duration of treatment was 10 days in both groups. There were strengths and limitations to this study. Some strengths are that there were no significant differences in demographics, medical conditions, or the surveillance categories, and there was approximately equal distribution of patients with irritable bowel disease in each group. Most of the authors had no conflict of interest, and it was approved by the Johns Hopkins University School of Medicine Institutional Review Board with a waiver of informed consent. However, there are limitations. Only 192 children were included, and there was no mention of power. The investigators did say that they used strict eligibility criteria like the need for hospitalization, even though we know that non-severe cases usually do not require hospitalization, knowing that they were going to compromise the size of their study, but they were hoping that would increase the validity of their findings. Also, it was multi-center of 3 different hospitals, but wasn't really multi-center because there are different strains of C. diff in the area of different geographical regions. So in order to apply this study to those different regions, we would have to see centers of all different geographical locations. So further studies would have to be done. It was also a retrospective observational study, so there's a possibility of missed data. And they assumed a clinical resolution if there is an absence of records, which may lead to misclassification, although there's no reason to believe that missing data would affect one group more than another. The propensity score inverse probability of treatment weighting was used to address imbalances in measured confounders, but since patients were not randomized, there's a possibility of unmeasured confounders. The authors concluded that the possible explanations for apparent improved effectiveness of vancomycin was due to metronidazole minimum inhibitory concentrations against C. diff that may be rising, although vancomycin resistance remains rare. Also, there's different absorption and fecal concentrations of the 2 agents. An important consideration to remember is the cost of vancomycin, and that many insurance companies don't cover it. So that's why a lot of prescribers may favor metronidazole as the treatment. Approximately 15% of the cohort did consist of children with irritable bowel disease, and it was equal between the groups, but it's very important to remember that irritable bowel disease makes it really difficult to differentiate between what is an exacerbation of the IBD and what's a CDI. So it does increase the real-world clinical decision-making, but it does compromise our study because it is a confounder. So there could be misclassification. As far as my own conclusions, I think that the guidelines that were updated in 2018 does not lead to chronology bias because it did not change the recommendation for children, only for adults, even though it was during the study. Also, I think that the higher population in the metronidazole group speaks to how popularly it's prescribed, and the secondary endpoint is not clinically significant. Due to the retrospective cohort design, it couldn't have been randomized, and the purpose was only to show association, not causation. It's only to further the support for more research to be done in children in order to change the guidelines. There could have been ways to control for no randomization, like inclusion and exclusion criteria, which they did do, regression and statistical analysis, which they did do, and they did weigh the groups to be more equal in size with the propensity weighted cohort. This was basically to put them on a more equal level, equal playing field, so that we could see the results of the 2 different drugs in populations that were more similar, since our groups were very unweighted because we had way more in the metronidazole group than in the vancomycin group. And there were more patients in the vancomycin group who had had a previous CDI infection. I think that the investigators could have been blinded when analyzing the clinical outcomes, but I think that the cohort was a good choice as a design because there's a known exposure and outcome and it wasn't a rare disease state. I think the length of follow-up was appropriate. However, I do think that this study could have been done better. They could have made previous episode an exclusion criteria, although it would have really impacted the size of an already small study population. I wonder how the results would have differed if they had done this, or if they'd had a larger patient population by enrolling more sites, and then they could have used that stronger exclusion criteria to control for the confounder of the previous episode. As far as impact on practice, I think that due to the high cost of treatment of vancomycin, the clinicians are still going to use metronidazole over vancomycin for patients whom cost is a barrier to treatment for, unless the guidelines change and then the insurance companies will change what they cover. I think that this study does a really good job of enhancing the need for more research in this area, but we can't really make any decisions based off this study alone because it's underpowered, non-randomized, non-controlled, and it doesn't provide a strong quality of evidence. Thank you for listening, and I hope you enjoyed my presentation.